Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by AASM. We have all interfaced with AI either intentionally or unknowingly. We have all used online chatbots and have experienced that sensation of our phones apparently listening to our conversations. AI has the very real potential of significant disruptive change to our world in general and in sleep medicine specifically. Our guests today are from the AASM Artificial Intelligence in Sleep Medicine Committee and recently published a position statement on the responsible use of AI in sleep medicine practices. Here to tell us more are Dr. Margarita Oks, a pulmonary critical care and sleep medicine physician at Northwell Manhattan, Dr. Subaila Zia, a pulmonary sleep physician and founder of Telemedora, an online sleep practice, Dr. Ramesh Sachdeva, a pediatric critical care sleep physician and attorney, and Matt Anastasi, an RPSGT and sleep team resources manager at the AASM. Please remember, this is not meant to be legal advice. Welcome. Glad you could all be here today.
Thank you.
Thank you for having us.
So, Matt, when we talk about AI, this isn't a monolith. So I'm wondering if you can break this down for us. What are the different types of AI that we may come across in our clinical practice?
So you're right. When we talk about AI emerging in healthcare, especially sleep medicine, it's not just one way. We're really seeing computers do a variety of things that were limited to human intelligence. So, recognizing patterns, interpreting signals, summarizing, making decisions. AI isn't brand new, but it's evolved. So what's changed is how it learns. So take machine learning, for example. It lets computers learn from data instead of just following a programmer's commands. If you feed it enough good quality examples, let's say sleep studies or treatment outcomes, it figures out patterns that help make predictions or classifications. Now, deep learning, this has similar outputs, but it takes the process of getting there a step further. So these models mimic how our brains process information. They're spotting subtle signals in either the EEG or wearable data. They're making predictions without being told exactly what to look for. So AI is basically, it's becoming essential in our day-to-day because a lot of the problems that we have to solve are just too complex. There's just too much data for humans or even fixed rules to solve alone.
So what about agentic AI?
So agentic AI is like a personal assistant who can do things on its own without actually your supervision. So it, for instance, it not unlike Gen AI, which just drafts the email but doesn't send it. Agentic AI can draft your email and send it, book your flights, update your calendars, and do much more beyond that.
So for like PAP adherence and follow-up and scheduling, maybe?
Yes, it does have a great role in that as well, as long as it's like your action assistant. So as long as you make sure that it is trained the right way, it can act on its own.
Okay, so those are three types. What about like generative AI? What's that?
So generative AI is a type of AI that is used for output focused creative AI or content creation, or it's like a pattern based AI. So it's like your creative partner, but it would not take action unlike agentic AI.
Oh, so like ChatGPT is generative, right?
Yes, ChatGPT is generative.
So what is ChatGPT trained on?
ChatGPT is trained on all kinds of things. It's including some social platforms or public platforms like Reddit.
Oh, really? Tell me about that.
So ChatGPT takes its input from different sources, and they are not they are not always clinical or peer-reviewed journals. So you have to be very careful when using ChatGPT, and it can hallucinate quite a bit if you do not prompt it correctly.
So then what percentage is, I'm curious about this, what percentage of it is trained, like comes from Reddit?
There is up to 20% can come from Reddit.
Oh, wow. You mentioned hallucinations, but I remember Azizi, he called it confabulation, which I think is a better word, right? It's sort of like, it's trying to link two sort of places, and it's just sort of making up how to get from A to B.
I would have to respectfully disagree with it, because
yeah, tell me.
There's a when Google rolled out its medical AI program called MedPalm Gemini, and what it did was it was supposed to look at the head CT and interpret it. It actually made up a stroke in a made-up part of the brain called basilar ganglia stroke, and they rolled it out to public. And it was not until a neurologist, who is also very savvy when it comes to AI, he called it out. And so, yes, it does hallucinate. So we cannot over rely on it. Otherwise, we are going to be generating a bias called automation bias. So
you don't think that's confabulation?
So I think it is more like hallucination. Yeah.
Interesting. So Margarita, tell me about this position statement. Is this sort of a new thing, or is this an update from the one from 2020?
So no, it's not a new thing. So the one from 2020 really kind of focused primarily on PSGs and how AI can help in scoring. And since 2020, the field of AI has been just progressing at exponential speed. And our goal 5 years later, and this should be coming out at the end of October, beginning of November, our goal with this position statement is to really allow the communities that read it to understand that we're now past the use of AI in scoring. We're now really looking at health disparities, at diagnosis, at treatment optimization, even documentation, monitoring clinical outcomes. And with all of that, there's a lot of issue in how do we make sure that AI is being used in an appropriate manner. And that was the approach that we took when we wrote this updated statement. We really wanted to focus on specific aspects of the use of AI and integration of AI in sleep medicine.
So what does responsible use of AI mean?
So good question. In the general kind of sense of responsibility in anything is doing something ethically and making sure that we're not harming anyone or anything. And with AI, because a lot of the training models, we don't know a lot of how those training models are actually being trained. And, like Subaila mentioned, we are using Reddit in some of these training models, and also the generative AI chatbots and all of that we have in the communities. So all of this is not really based in the scientific method, right? And that's the problem. So the responsible use of AI, I think, to me, and probably, our committee, means that we have to be an educated consumer. We have to understand the pros. We have to understand the cons. We have to understand, the issues with integration, implementation, from medical legal to privacy to fairness, transparency, because there's so many kind of black box things that we just don't know about AI and how it's being given to us.
So when I read the position statement, I noticed it was like pretty short. Was that on purpose? Like, is that intentional? And then the language also didn't seem super complicated. Is that because it's AI and not really talking about medical things, or was that also intentional?
It's intentional. So
Okay.
the AASM has decided to standardize the way that its position statements are written and released. They're really, even though it's the AASM and it's really designed for the sleep medicine, practitioners and practices, et cetera. But anybody, let's say in the government, anybody in, a family medicine practice should be able to pick up this position statement and really understand what we're trying to get across. So it's really not meant to be all inclusive and very, detailed in terms of the physics of AI or anything like that. It's really meant to be an overview of what the position is, and that has to be accessible to everybody can have their hands on it.
So like when we're advocating for sleep medicine and we want to share that position statement with like lawmakers.
Correct.
Okay.
Exactly.
I got you.
Exactly.
So can we go through the major points of the paper, right? Because you kind of talked about the considerations when implementing AI into a sleep medicine practice. So Subaila, can you walk us through this?
Sure. So there are four major points in this paper, starting with the data privacy, which is very important, and then is the fairness and transparency, infrastructure, and medical legal. So basically, data privacy means that as with the rapid adoption of AI, we are also going to see more and more cybersecurity attacks. So we have to make sure that while we are adopting AI, we are not only very diligent, but we are well prepared to reinforce our data privacy standards to avoid all these kinds of ransomware attacks. As far as fairness and transparency is concerned, so like Matt said, that fairness in AI means minimizing bias through diverse representation in data set. And transparency basically means that AI tools that explain their own outputs clearly to the users. So both fairness and transparency are very important when it comes to creating trust and accountability. So whenever we are deploying these tools in our which are AI-based sleep technologies, we need to make sure that these technologies are trained on what we call representative data and also free of bias data. So by representative data, I mean they should include different races, ethnicities, gender, socioeconomic status, and for bias, we should keep in mind that there are electronic health records. Not everybody has access to wearable technology and so on and so forth. So, and after our work won't be done, once we implement these technologies, we have to have continued validation of these AI training models so that they do not become poisoned with unreliable data.
Okay, so that is about fairness and transparency. The next part of the paper I saw was infrastructure. Tell me about that.
Yes. So for infrastructure, it needs to be a collaborative approach. And also organizations will need to be equipped with both on-site and cloud-based computing systems, because by 2030, we know that most of these servers would be cloud-based. So they need to be well-versed with it, and they need to make sure that these servers are HIPAA compliant and are in also they have very stringent, again, data privacy and security protocols in place.
So how do you know what a model was trained on? You talked about equity and you talked about, kind of understanding it. So how do you know?
Great question. We could actually ask AI developers and AI vendors to share with us that the type of data that they trained their model on. And we also need to make sure that they trained it on sleep-specific data. They should have clinical validation studies there, and they should have diversity check audit logs or bias check audit logs if they can provide that.
And it's also, I think the biggest issue is that this is not well regulated by the
Right.
federal government. So that's where the issue comes in. So to answer your question and piggyback on what Subaila is saying, it really is on these companies to have the same attitude that we as clinicians in the medical world have.
Okay, so tell me more about that. Like, that feels very empowering to be able to ask the companies about how they trained their models.
Yes, I mean, it should be empowering, and we want to have that transparency from the companies. But, unfortunately, because there's no federal mandate and the U.S. is very much lagging behind, actually, from the international perspective and regulation of AI, even though the prior administration tried to have some implementation with an AI executive order. That's where the biggest problem is that if the company is not willing to release whatever validation sets they're using and how they're training their models, then we don't know. They also theoretically can tell us anything, right, that we want to hear in order for us to, purchase the models, right? And that's the problem. So we really do have to rely on the companies trying to be ethically and responsible from this perspective. And it's very difficult. Not everybody probably is, because there's a lot of financial, consequences.
Yeah, that's fair. That's fair. So then the next part of the paper talks about infrastructure. What do you mean by that?
So that's really the ability to have an AI system fully integrate into whatever the clinical environment really is, right? And that does include some of the other things that we discussed: the data privacy, the learning models, the paying attention to the validation sets that we're using, things like that. So it's really being able to incorporate whatever AI system one has and ensuring that it's HIPAA compliant, that you have the medical legal system in place, that you have, that the clinicians are trained, they understand the implications of using AI. So it's really kind of the overarching implementation of an AI system, because, the way it stands now, the tech is moving at such a fast pace, and the real bottleneck is actually not the tech, but the implementation, which is usually the infrastructure for most medical systems and private practices and, medical environments.
Yeah, I believe that. And I also feel like there's sort of this concern, right? There's this legal consideration, right? This sort of medical legal component of implementing AI into a clinical practice. Ramesh, tell us about this.
Yeah, thanks, Seema. Before we jump into the medical legal factors, just wanted to go back and just point out one or two other items that came up in this discussion. So just going back to the remarks about generative AI, I do want to point out that despite all the hallucinations and the concerns, things like ChatGPT, there are newer iterations, like, for example, ChatGPT 5, which is relatively new, that actually is intended to minimize some of those hallucinations. And there are other techniques that are rapidly emerging, including fine-tuning and so on, to help minimize some of those. So I think, the landscape will look very different very soon. Coming back to the question about the medical legal implications, I do, again, as you mentioned earlier, Seema, just wanted to again reiterate that this part of the discussion is only for education and not for any legal advice. But as the paper itself, the position paper points out, the area of the medical legal landscape itself is changing very rapidly. Courts are struggling as to how to deal with AI. It's new. The technology is ahead of legal precedents in many times, so there's no clearly defined law. I think the takeaway message is that a physician or a clinician cannot hide behind the AI and say that they are not responsible, it's the AI's fault. So certainly AI may give potentially an inaccurate recommendation. We some of that came up early in the discussion. But ultimately, it's still the clinician, the sleep physician's responsibility to make sure that the recommendations are vetted, evaluated before executing those recommendations. So the takeaway message here is that we just can't say, oh, it's the AI's fault, so the clinician is somehow not responsible.
So let's take a short break, and when we come back, we'll talk more about the responsible use of AI in sleep medicine. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking with members of the AASM AI Committee about their recent updated position statement on the use of AI in a sleep medicine practice. So we are expected to use AI responsibly. I'm hearing you. How do we know that other people are also using it responsibly? So what I'm thinking about is insurance payors. There was one that was using AI to deny thousands of claims without even looking at them. So that seems like an unfair playing field, right? If we're held to these strict standards, and yet how do we know that other people are also being responsible with AI?
We don't know that yet. And to build upon Margarita's point of view, that she earlier said that we need much more stricter standards and a federal law in place to disclose these things whenever they are used in medical AI. And some of the tools that are being used today in the clinical workflow, like AI scribing and other things, that are not considered medical AI so far, and that is scary. Just like this payer that there were a couple of payers which have been sued for relying on only an AI tool to predict and to deny thousands of claims for patients. Then the developer of that prediction tool turned around and said that the payers misunderstood the role of technology.
Right.
They were just supposed to evaluate what to approve, not to decide whether to deny it or not. But the payers are saying, no, we did have humans in the loop. However, their internal documents showed that even though they had these clinicians in oversight on some of these cases, those who did not agree to their decision, they were penalized.
Yeah.
And I think that humans would always be in the loop because we cannot. Otherwise, who are they going to hold accountable? Currently, there's nothing like AI personhood there, which means that AI algorithms are not legal citizens, so they cannot be held accountable in the court of law.
But it feels like such a hot potato, right? Insurance is saying, oh, well, this is AI. And then the AI company is like, no. This was not meant to deny claims. It was meant to approve them, right? So they're all sort of tossing around the responsibility.
Yeah, Seema, if I may just add, actually, there is a emerging school of thought in the legal community that an AI could be an entity in itself, but ultimately who owns the AI? And that's particularly relevant for this notion of agentic AI, which we discussed earlier. So the AI, an agentic AI model is making decisions, right? It's not just providing information to the user, it's making autonomous decisions. So is it its own entity, if you may? So that area is very fuzzy, but I think stay tuned. This is I think there's going to be evolving legal doctrine on this area in the emerging days and weeks and months ahead. Well, I did have a question for Subaila. In terms of I know there's also this big movement, as you know, towards open access AI, where AI algorithms are available to other developers. So it's not a closed system, it's an open system. And many new AI models, large language models, pride themselves of being open source. So in that situation, what do you think would happen in that situation? How would that impact some of the points you were making earlier?
Yes, I think as long as we have fair standards to determine if they were trained on representative data and to prove that they are reliable and their outputs are safe and consistent, I think that is a great source for further development of AI. The problem is that we do not have any standards yet to say that this is for representative data right now.
And, I think it's also interesting, Seema, that, the insurance company you're referring to, all of that came out from investigative reporting, keeping them honest, right? So there almost has to be this third party, unless we get some regulation that is going to keep all of these companies honest, because we don't know what we don't know. And this is going to continue. And AI is going to continue to expand more and more. And unless there's some more regulation in place, I think this is going to continue to be the wild, wild west.
It is. And it's common sense too, right? Like if you look at the amount of time it's spent on denials, like I physically can't click fast enough to do that.
Correct.
Right? So then it just, it seems silly, right? Like I'll use ChatGPT through Doximity. Like I've played around with it to generate an appeal letter. And I would read it and I would look at, and one of the references I'd never heard of before. So I was like, aha, it's making this up. And no, it was real. It was a real reference. And I learned something and I was like, oh, this is great. But it's almost like our AI is fighting their AI. And I'm like, maybe we just let them kind of go at it, leave us out, let us know where it ends. Like let us know when a human needs to come in.
Yeah. I mean, the problem is I think that the human should, in my opinion, never leave.
Right.
And we need to keep pushing to ensure that we have that oversight at every single part of this, because I think, it makes AI makes things a lot easier, but it doesn't make those things necessarily right.
Or better.
Or better.
Yeah.
Exactly.
But it's kind of a different mindset. Like I remember speaking with the engineers behind one of the newer home sleep apnea tests like years ago. And they were really, really sort of digging their heels in. They're like, well, no, you don't have to look at the raw data. Like, we are better than you. And I'm like, no, I have to look at the raw data. Like, it's not only a requirement, but I'm like, I like to see it. And it was such a bizarre conversation because they were like, well, it doesn't matter because you're not going to be better. And it just was like a different mindset, right? And so I feel like that collaboration and like to your point, like a human needs to be there, like a clinician needs to be there.
Yeah, because they're overconfident when it comes to their own data sets or their own AI. Some of them are overconfident to the point of being dangerously overconfident.
So do you need to inform the patient that you're using AI? Like, what does that look like? Do you have to be specific? Do you have to say, yep, our scheduler is AI, and yep, we use, PSG scoring or an AI scribe? Like, what does that look like?
Yes. So although there is no federal law in the U.S. to mandate disclosure or obtaining informed consent from end users like patients when medical AI is used in clinical care. However, I feel that being transparent is the right thing to do when using AI in clinical workflows, because it fosters trust and it allays the anxiety and fear people have around using the AI in their workflows. So, however, I'm based in California. As of California is the only state so far as of January 1st, 2025, that has that requires clinicians and facilities to disclose to patients if Gen AI is used to communicate patients' clinical information, unless it is read and reviewed by a licensed healthcare provider. And
that's interesting.
Yeah, not only that, they also need clear instructions for patients to how to contact a human healthcare provider. And they're very specific about when to introduce that disclaimer. For instance, if it is or if you have an AI receptionist, you should that disclaimer should be at the beginning as well as at the end. If it is a video telehealth, it should be throughout, and if it is a written letter, it should be that was generated by AI. It should be at the beginning.
Yeah, that makes sense. I've seen notes where they have that little squiggle line to show that it was like an AI scribe. Like I've seen that on different like hospital notes and stuff. But I'm kind of wondering about the burden, because do you actually have to physically, like when I was using an AI scribe, I would inform patients at the beginning of the visit, hey, I'm using this AI scribe. But it just seems like yet another thing that we have to do.
I don't think so that it is. It will create a burden for the clinicians. At least for me, when I use AI Scribe in my clinical workflow, it does. Patients are very grateful because I'm not focused only on typing. I'm also looking at them through telehealth, and also they really appreciate the transparency, because what I tell them is that it is. AI is going to make me faster and more efficient, but I would always be in the loop when I'm taking care of them.
I think it depends on the focus too. So the need for that full transparency is really great when AI is involved in something that really impacts directly on patient care. So if there's a medical device involved, if there's a clinical decision support that AI is involved in, or even if a patient is interacting with an AI-driven chatbot. But on the other hand, like if there's AI being used in administrative work, scheduling, back office functions, why burden patients unless it's necessary to do that? If you go back to the position statement, AI should never be used for making, the AI should never be the decision point on clinical, that would impact patient care. So the physician, the care provider is always the one that makes that decision. But, when it comes to transparency, it really does depend, and getting consent for transparency is another whole ball of wax, because that's kind of more of a conversation with patients about understanding, but transparency is absolutely essential.
And I imagine it's different in different regions, right? Like Subaila, you're in California. I bet they're very sort of pro technology and AI, whereas where I am, it's not always, you can kind of see people give you a look and be a little concerned, even with CPAP downloads, right? Like Big Brother's looking at my CPAP. And so I think it really does depend on where you practice.
Yes, you're absolutely right. So I would share a very interesting an anecdote with you that and with your listeners. Couple of weeks ago, I was getting this consent for an AI scribe. So my patient said, "Oh, by the way, Dr. Zia, I'm also using AI scribe in our conversation, and the one that I'm using it is actually the one that I'm developing."
No way.
So
So is there a framework we should consider? Like, what are the guardrails? How do we do this?
So ideally, implementation of AI should be a collaborative approach. If you want to have a win-win, it cannot be done in silos, and you have to start with being secure. Data, when it comes to data security, it should be transparent. Using explainable AI, it should be fair. You should only use AI tools which have been clinically validated with clinical oversight. Like Margarita said, human clinician needs to be in the loop especially when you're using medical AI tools for the final sign off, and there should be ongoing monitoring for accountability.
So let me ask you this, and this might be a Ramesh question. So if you're an employed physician and the system has made the decision to use AI, are you liable as the physician using AI if AI makes a mistake?
That's a great question, Seema. And once again, there's no clear-cut answer. But the way, at least I would think about this, is that I think there are 2 points. One, ultimately it's the physician who is responsible for the clinical decision making, no matter what sort of technology is used. And AI is a new technology, relatively new technology, but we have had other technologies in the past too. So there's precedent from that standpoint. But I think your question that if an organization makes a decision to have a certain AI uh, technology, where does the liability lie? Well, the physician cannot totally get away with it, cannot absorb himself or herself from it because they are the people using it. But having said that, that introduces another concept called vicarious liability. Vicarious liability, which means really that the organization, the hospital, a sleep clinic, or an entity, they may also be liable for decision making, even though they themselves are not directly interacting with the patient. So, in other words, a hospital makes a decision to buy an AI technology, the physician is using it, there's an adverse outcome. The physician is still potentially liable, but the hospital could also be pulled into that, both from a standpoint of decision making of that technology, but also because of the poor decision making by the physician who used the technology who was in their facility. So that concept of vicarious liability.
So what about the other way around? What if you ignore an AI prompt? Is there a
Yeah.
liability with that?
Yeah, that's a great question. And once again, no clear-cut answer. But there's questions of errors or problems of omission or commission. Meaning, commission meaning you do something, the technology says there's an adverse outcome. Well, the point is the physician still needs to, as has been said numerous times in this discussion, there needs to be that human touch, the human oversight, the human interface. But conversely, the other point is that the technology makes a recommendation, the AI makes a recommendation, and the physician disregards it. Well, if there is a rationale and that there's a justification, and hopefully there's some documentation that these are the reasons why that recommendation was not followed, that provides some level of defense or an argument. But if one completely ignores an AI recommendation that doesn't even see it and just dismisses it without giving some thought, that could pose a risk.
2025 marks the 50th anniversary of the AASM. Here is Dr. Abreu talking about AI and the future of sleep medicine.
I look at the future of sleep medicine being very interesting because we are adapting to AI. So how can we make AI be something that's reliable and is safe and is going to add to the practice instead of remove providers from the practice? Because as perfect as AI is, if you have an error of 10% in medicine, is 10% too much? Yes. For me, an error in medicine of 0.1% is too much. My brother's a lawyer. If he makes a mistake, he can appeal tomorrow. If we make a mistake, it may cost our patient's life. So the academy is essential in that. So when you look at the future, I see AI integration to the max, where a provider can now assist their patients in a much better model, where I can interact with my patients remotely via messages that I create. They're important for me, how to manage my patients so they can feel taken care, they feel included, they feel loved, and they feel that they have been heard, because that's one of the problems that has happened with medicine from my standpoint of view. We became automatic. There's too many patients that we have to see every day because of lack of reimbursement, and then you start feeling that you're losing the touch of your patients. So I'm looking at AI as integrating not just computing and taking us out of the picture, but actually allowing us to become more humane, because we're able to use AI and we can spend our time taking care of our patients as a person, not just as a number.
Now back to our conversation. So, Margarita, is using AI inevitable for us? Like, I'm kind of thinking about my colleagues that just really don't want to use it.
Oh, 100%. I mean, it's already here,
Set
right?
up.
I mean, and I struggle with this because I know that, and I also am surrounded by colleagues who are not as interested, but everybody's using it. You're using it on your phone, you're using it on your TV, you're using it in possibly your car, right? If you have an electric vehicle. So we're already using it. So I don't understand the hesitation with using it in the medical world if one is fully aware and has kept up to date with kind of some of the difficulties, right? With any new technology. I mean, if you guys, I wasn't around back then, but I know the stories when, the first Mac computer came about, right? I mean, the turmoil and everybody was going crazy. And, it was just everybody was, when the BlackBerry first came out, right? It was just this huge response. What is this? What is this? And then people eventually, really adapted. So I think the hesitation shouldn't be there. We need to be very educated in how we implement, how we approach, how we think about this. It's not the solution. It's just part of our arsenal in medicine, and I think that's how I think about it. It shouldn't replace us. It should help us. And I think if people start changing their, minds and shifting their mindsets about AI, it's going to be a completely different attitude.
Yeah, you're
Yeah.
right. If you recall, back in 2000s, when paper charts were being replaced by EMR, if you recall the kind of resistance that was given by clinicians to the administrators, many of those clinicians who, regardless of their stature or experience, they were strategically weeded out of the workflows. So now you have much more tech savvy physicians in the workflow. So yeah.
Yeah. Yeah. Every technology just it goes through something called a hype cycle. So there's like a need for something and a trigger, an invention, and it just sort of steamrolls to this peak of expectations. Like the smartphone kind of reached this in 2007. It was thought to be the savior that was going to replace music, obviously the phone, computers, laptops, you name it. And after that hype, kind of dies down, it reaches this reality level. We call it the trough of disillusionment.
Okay.
And it's kind of where the problems are worked out, like the technical issues, it's kind of where we are right now with AI. So AI has gone past the ultimate hype where it's going to, replace every single function that we have. And we're starting to realize that, hey, there's some real issues with privacy that we have to deal with. There's been, they've interviewed 83% of physicians have experienced a cyber attack. So the need for
Holy
infrastructure.
moly. Is it that high?
Yeah.
Wow.
And 85% stated they want to share electronic PHI, but we're concerned about the data security necessary to protect it. There's a lot of things that are cropping up now. That's why this is a really good maturity level for this position statement. Of course, 5 years, a lot can and has happened. In 2020, we were at a real optimistic level. I mean, maybe even hype. But in 2025, we're at a level where we're kind of maturely looking at this and saying, why is there a clinical lag? So the technology has really gone so far beyond what we're using it for right now that we kind of view this position statement as a way to kind of a blueprint to kind of gain that trust in a responsible way, as we use that word, through these different tenets that we lay out. And those guardrails really with the absence of laws and anything external is that clinicians are the ones that really have the expertise, not only to evaluate, the performance and we're in the best position to basically say whether or not these tools are needed, whether or not they're really having a better impact than our current best practices. And then we're in the best position to monitor it over time and as it evolves. So we kind of see our membership at the AASM as the ones to really use this position and be able to ask questions of ourselves and ask questions of our vendors.
Well, I love
Yeah.
that ability of asking questions of the vendors, right? And
Yeah.
and I'd like to explore that a little bit, but I'm kind of wondering, Margarita, do you have advice for sleep medicine colleagues for how to incorporate AI into their practices? So I hear what you're saying. You've got
Right.
colleagues that don't want to do it. So how do you help them with this?
So I think a lot of it is education, because I think with education and really understanding what AI can and cannot do, people become less fearful, and then people are more accepting. And I think it really does depend on the resources of each individual practice and system, and starting small, right? So I think even starting from ambient listening and the scribe softwares that are available, just to kind of get somebody's feet wet, to prove to him or her that it's not that big of a deal and could be actually helpful, right? If done right. That's always the disclaimer, if done right. And then as you kind of start to build up little by little, then you can introduce, home sleep apnea testing systems, right? Go, to PSG scoring systems, etc. So I think it has to be done little by little, and then the interest has to be there, right? So the motivation has to be there to kind of start to expand it more and more, based on the resources that are available.
Subaila, how about you? What advice do you share with your colleagues?
I tell them that it is better to learn AI than to be replaced by a clinician who knows AI. So number one. Number two is that I always encourage them to start with at basic level, bite-size training. For instance, just learn how to do prompting correctly, to have much more accurate AI responses. And also, it is important to do staff training, which is role specific, because nobody has time to sit through hours of training. And also, for the AI vendors, I would tell them to please make AI tools that are integratable in our workflow, that we actually need, not what you think we need. So as clinicians, we deal with these things on a daily basis. We deal with patients. We do need this. We do need a collaborative approach with the AI vendors and developers. They need to keep us in the loop.
Yeah, and that's so true, right? Of all of this technology, help us get what we need, not what you think we might need. Yeah, that's true.
Yeah. It's really the buy-in, you know what I mean? I think it's the buy-in.
Yeah, no, I think you're exactly right.
That's the most important thing.
So, Matt, let me come back to what you had kind of talked about talking to the industry. And when we had chatted earlier, you said something that I thought was really kind of profound about planning for equity. Like, what does that mean? And what does that mean for our role in how we communicate with industry?
Yeah, it's not a passive approach. It's creating a governance plan. So making sure all the things we mentioned earlier are in place. It also, we talk about the vendor, but we need to ask ourselves questions too. Like, if we're considering technology, what is the current problem that we have that we're looking for AI to address? Is it really necessary, or is it just a nice to have? Also, are we giving, when we get to the questions we ask vendors, are we giving the AI tools that have a greater impact on patient care a higher level of scrutiny compared to the
Oh,
ones that are really just impacting back end, administrative processes?
I mean, probably, right?
Yeah, well, that's key is that, we don't just give everything the same, process.
Huh.
Sometimes we're a little hesitant to engage with vendors because we have to go through a list of security questions.
Mm-hmm.
But maybe those security questions should be more when it's impacting clinical decision making and not scheduling. So just
Okay,
something to
so
keep in mind.
but we can control what the models are trained on, though, can we?
Well, we can ask. Right now, most users really aren't even asking. For example, is is the algorithm trained on standards that are accepted in our field, like the scoring manual? Are the AI algorithms making decisions that are compared to experts in the field? Um, we're not taking AI um, products and testing them out in sort of a quality assurance type of approach side by side with our manual practice of, for example, scoring and seeing whether there are differences. So even without having like insights into the black box, there are
Mm,
ways to have insights into how the black box is trained based on how the algorithm performs. In other words, we can ask whether a system's been tested on diverse patients and populations, but if we test the algorithm on diverse populations and it
mm,
doesn't perform well, then that's kind of a clue that it was tested on maybe 100% healthy people, or
yeah.
all the people had OSA, and then when it gets into a real situation with our real world patients, it doesn't know what to do with it, and it gives inaccurate results.
But then you have to sort of have your antenna up though, right? To look. Because
Mm-hmm.
if you've sort of
Sure.
accepted it, right? Like that whole automation acceptance, if you've accepted it, then maybe you are less likely to scrutinize it.
Yeah, that's why, thinking of ourselves as as the experts that are really in the best position to monitor the technology over time is something I think that we're not used to doing. We're not used to being that educated consumer, but we
Yeah.
can monitor that over time.
Well, can we talk a minute about AI scoring of sleep studies? Like
Yeah.
they get FDA cleared, right? Um,
Right. Right.
is that enough? Like, is that a high enough bar? Like, how rigorous is the FDA clearance?
Well, I went to the FDA, which it's not completely updated right now because of the shutdown that we're going through, but it has 1,200 at the time AI enabled devices FDA cleared.
Oh,
And my
wow.
guess is that not all of those are on the same level, right?
Yeah, that's fair. Yeah.
So, I what we've done at the ASM is we had a pilot for auto scoring certification. It was limited to stage scoring, and it was limited to a couple years. So we had companies give us their software, and we basically just installed it locally, cut it off from the cloud, so they would have no influence, and it would basically be a third party neutral our validation of the performance of auto scoring. And we feel like this is a higher bar than the FDA because the FDA is self-submitted data from
Oh,
research
okay.
that's done by companies. So what we've done is, we did it in a pilot way, and we're going to roll out a full PSG. So not
Mm,
just stage. probably around we're targeting prior to Sleep 26 in Baltimore, where we would be able to have companies send us their software, do a really thorough test, compare it to, we have a huge panel of manual scores. They're scoring
Oh, sure.
150 records, which
Yeah.
is, 2,250 individually scored record with a panel of 15. So it's a big undertaking, but it's really the best way to give an unbiased performance evaluation of auto scoring software in the most fair way. And
Is that from
yeah,
like the ISR data?
no, it's actually, these are studies submitted by accredited sleep centers from geographic regions throughout the United States, and the distribution of pathology and
Huh.
ethnicity and gender and age is really really good, really robust. And those studies are new, and they've never been scored before by AI. They've never been seen by AI, and they've never been seen by like any of our gold standard panels. So
Oh, wow.
these are new records. But the interesting thing is that, this is not, it's an oversight over technology, but it's something that, believe it or not, the vendors, the dozens of vendors that we've worked with on this program, they've given insights. They've had a seat at the table on the committees. And through this process, I was a little surprised, but they would say things like, "Oh, I've invented this algorithm 10 years ago, and I've been waiting my whole career to have it validated by you guys.
No
We really,
way.
we really believe in, our software, the advantages that it has, and we really want a platform for that."
So, Subaila, you're in California. You've obviously embraced AI. I'm really curious about where you see AI taking us in the future.
So we are in this transformative phase of sleep medicine with all these AI-based sleep tools coming out, both on the clinical side as well as on the consumer side. So the future would belong to those who can embrace these technologies, understand them, and then deliver personalized care to patients. And also, I see that AI would help us become much more efficient, faster, with better turnaround times for automated scoring of sleep studies. And it is going to basically reduce clinical and administrative workloads. So without replacing us, it would definitely replace those clinicians who are not AI savvy, but it would not replace those who are. And that is according to the data from Health Labor Statistics, which is as of August 28, 2025, which showed that out of the top 20 jobs in the US market, at least 12 belong to healthcare, with
Oh, wow.
with nurse practitioners being the fastest growing.
Huh.
Third fastest, sorry.
Do you think we can trust these AI assisted programs, Matt?
Well, it's earned, it's a process of putting in place, I think, a governance plan. If we go back to the hype cycle, a lot of those technologies dropped off, and we're never seen again. But something like AI, the reason it's going to stick is that it's going to have an impact in so many areas. We call it like a plateau of productivity. And the
Oh,
way to get there is, where we were in 2020 is we were just kind of, in that hype. We were just looking at this new technology, and we're really optimistic. But now, by putting in place, 5 years later, a lot has transpired, putting in place these tenets that we have in this updated position statement, we really feel that is going to be a really opportunity for clinicians to close the gap, because the technology has really gone far, but there is that clinical gap, that clinical hesitancy, and really closing the gap is going to take clinicians who are really best positioned to evaluate AI solutions, make decisions on which ones to use, and then also, most importantly, be able to just monitor it over time.
So tell me about AASM Link. I keep getting emails about it. What is this?
Yeah, it's it's kind of a AI assistant, but it's completely different than the AI assistants that people are familiar with that just scrape data from the internet. You had mentioned 21%. That was a GPT-3 model.
From Reddit?
Yeah.
Yeah.
And actually, I saw where the fourth model had used 40%. So it actually used more.
40% from Reddit.
Yeah, because of a exclusive contract. So what the ASM has done is taken only ASM, only work that the ASM has put together from our dozens of committees, ICSD,
So
the
it's trained on
scoring
trained on ASM resources.
Yeah, it's 100% ASM resources trained. And so this AI assistant, when you go to it to ask questions about scoring or about diagnosis, it's it's as close to being trusted as we can make it, because all of the training is pristine. And it is free. It's available to any member. There's some limits to the monthly usage of 15 conversations, but anybody has access to try it out. AASM link.
Oh, that's cool. So where do you see AI taking us in the future?
Well, I think it's the sky's the limit. I think it's going to be basically take away any task that is repetitive, that clinicians and sleep techs and support staff have to do. And there are, when you break it down, there really are a good number of those repetitive tasks. But, clinicians kind of think in a non-episodic way. I think that's a way to describe it, where they get information from a lot of different sources and come up with conclusions that aren't necessarily in a linear fashions like AI would do.
Yeah.
Like there's the show House. Have you ever seen that show?
I could never watch it. My husband loved it. He's a nurse, and I would when they would break into people's houses to get stuff, and everything was sarcoid. It drove me crazy. I couldn't watch it. So I digress.
Yeah, there's this episode that it just perfectly illustrates the fact that the standard processes that physicians will take to determine a diagnosis. There was a patient that nobody could figure out, and he asked a couple questions like, "Oh, those jeans, were you wearing them when you got sick?" And he said, "Where did you get the jeans?" "Oh, from a street vendor." And they were able to find they went into the kind of the bowels of the hospital, dig out these jeans before he changed into a robe and everything. And they were actually able to scrape, I think it's Kineset. There's this poison.
Oh, like the creosote stuff.
Yeah,
like
there was
that?
this poison. It starts with a K that
Okay.
he ingested, and it
Oh, jeez.
caused all of these cascading medical complications that mimicked other diagnoses. And an AI algorithm would never ever be able to come up with that solution. And I think that physicians and sleep technologists, they deal with decisions like that every
Yeah.
day, all day. Patients come in that you think are going to be fine. I'm a sleep technologist, so I could tell you that you can read the chart and everything seems fine, but they'll come in
Mm-hmm.
and they'll have bottles of plain alcohol falling out of their bag, and they'll
Yep.
be
Yep.
or they'll come in a stretcher, or
Oh, geez.
there's
Yeah.
certain things you just can't predict, but you have to. It's only human beings can handle,
Yeah.
especially in healthcare.
Yeah. Well, and it's funny because, like, if they could find those genes, like, I
Yeah.
lost my watch as an intern during a code, literally couldn't find it ever. So kudos to
Basement.
House for finding those genes. Basement's probably where my watch is. So, how can we protect ourselves against these legal pitfalls?
Yeah, Seema, so I think really in my mind, it comes to some basic good practices
Mm,
like we always do. And rather than thinking of AI as something completely new, think of AI as a the next iteration of a new technology. We have had new technologies all along in our clinical practice, clinical decision support systems, uh, electronic health records, other apps that are used by some people. So if you think of it from that standpoint, so making sure that there is cons- consent when needed, and this was brought up earlier in this discussion. So there's informed consent if needed and as needed. There's transparency, there's a thoughtful and responsible use of the output from the technology. And again, to reiterate the point that the clinician, the provider, the physician is ultimately the decision maker. So incorporating the output, but not blindly following it or not
mm,
blindly ignoring it, putting it in context. And finally, good documentation. The AI processes don't replace good practices of documentation. So, for example, as Subaila was mentioning about AI scribes, well, the output that comes out that still needs a thoughtful review before it's signed off by the provider.
So, are there any other legal considerations as we move forward with AI? And where do you see AI taking us in the future?
Yeah. So I think the first step is that the entire legal landscape with respect to AI, as I mentioned earlier, too, is evolving. So it's important for clinicians in the field of sleep medicine uh, to be aware of the new developments occurring. Uh, AI is a unique technology, I think, to the extent that the technology has gotten ahead of clinical and maybe legal practices. So there's a
Mm,
lot of catching up to do, if you may. So making sure that we stay up to date of what's going on, and these sort of sessions, educational venues, provides a good mechanism of sharing new information and other opportunities from AASM. So I think some of this will evolve. I think there are some real questions on the horizon in the near future. This issue of regulation at the federal level and at the state level of AI. How does this fit in with international regulatory movements going on? So that's one entire area. The other is from a liability standpoint. To what extent and how would AI be held accountable? Will it be the developer, the owner of the AI technology, or the user? And again, all three could be involved, and even the vicarious liability concepts that we talked about earlier. But how exactly is that handled? What are the details? So some of that, I think, only time will tell as cases are litigated and new legal doctrines evolve. I think the other question which you have as to where is all this going is fascinating. As a clinician myself in my own clinical practice in sleep medicine and in pediatric critical care medicine, I think AI is going to have a significant impact. And I think if we use it well, hopefully it'll make us more efficient and effective clinicians. So I think that's the real importance of this entire movement, is not to replace the clinician, but hopefully make us more informed users, and in turn be able to provide better care for our patients. The other piece which came up slightly in that conversation, but I do want to emphasize, or where things are going in the future, is that many of these AI modalities are also increasingly being made available to patients and families and consumers, right? So I know Subaila shared some of her experiences, but I think our patients we take care for in the future are going to be even more informed of various medical conditions and treatment modalities. So as clinicians, I think it'll be important for us to be cognizant and aware of that, to make sure that we can meet the needs and expectations of our patients.
Well, thank you all for joining us today and helping us to better understand how to incorporate AI into our clinical practice while also ensuring that we use it responsibly.
Thank you.
Thank you so much, Dr. Khosla, for having us on this podcast. And as member of AI Sleep Medicine Committee from AASM, I truly appreciate the fact that you gave us this platform to highlight our updated paper on the position statement for artificial intelligence in sleep medicine. So it would be out in November, and the timing couldn't have been better. Thank you so much.
Thank you so much for having us. We were going to try to get the whole committee on, but we had to draw the line somewhere. So thank you for welcoming the four of us from the AI and Sleep Medicine Committee. And, we really thank you for having this platform to just progress the conversation along just a little bit. And hopefully
it's your platform. It's all of us as members.
And I look forward to seeing you at Sleep Medicine Disruptors, or watching you.
Yeah, it should be fun, right?
Yeah.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.